1967, Delta Sigma Theta Sorority Incorporated established the Delta Research and Educational Foundation as a public charity supporting scholastic achievement, public service programs, and research initiatives focused upon African American women and their families. Today, DREF remains strong, vibrant, and poised to meet 21st century challenges with the same unwavering spirit and dedication the sorority originally envisioned. The charge to realize social and economic equality for future generations of African American women continues as the guiding principle. Since 2017, DREF has received funding from the National Institutes of Health to continue its role as a national community engagement partner to promote the All of Us research program through a community awareness campaign that informs African Americans and minorities about the importance of understanding and participating in biomedical research. The National Health Initiative, conducted by the Delta Research and Educational Foundation in collaboration with Delta Sigma Theta Sorority Incorporated and the National Council of Negro Women, is entitled Research Matters: Creating Possibilities to Achieve Health and Wellness for All of Us. The objectives are to engage, educate, and ultimately enroll African Americans in the National Institutes of Health All of Us 1 in a Million campaign, a national database primarily comprised of diverse and traditionally underrepresented populations. The mission of the All of Us research program is simple. It is to speed up health research and medical breakthroughs by asking 1 million people to lead the way to provide the types of information that can help create individualized prevention, treatment, and care for all of us. The All of Us research program is a part of the Precision Medicine Initiative created during President Obama's administration. Precision medicine is healthcare that is based on you as an individual. It takes into account factors like where you live, what you do, and your family health history. Precision medicine's goal is to be able to tell people the best ways to stay healthy. If someone does get sick, precision medicine may help healthcare teams find the treatment that will work best. This will help give healthcare providers the information they need to make tailored recommendations relevant to people of different backgrounds, ages, or geographic regions. African Americans continue to have some of the highest incidence, prevalence, and mortality rates from chronic diseases such as cardiovascular disease, diabetes, obesity, hypertension, mental health, and HIV/AIDS. Yet we comprise only 5% of clinical trials participants in America. Our focus and objective is to create awareness about how research matters in closing the health disparities gap. DREF seeks the assistance of national organizations, local chapters, sections, community leaders, and organizations to make the All of Us research program a successful endeavor. The influence, leadership, and participation of the aforementioned groups are needed to assist in promoting this groundbreaking opportunity. Individuals, groups, and organizations are welcome to assist with conducting and/or identifying outreach activities. Training, materials, and monetary resources may be available to support groups and organizations with approved collaborations. Please send an email of interest to researchmatters@deltafoundation.net outlining upcoming activities and events in which the All of Us research program can be included. For more information, please visit www.joinallofus.org/DREF.
Good evening, and welcome to Breaking the Genetic Code. I am Dr. Maria Smith-Dixon, and I serve as the Engagement Coordinator for the DREF Research Matters for All of Us initiative. On behalf of our team, Happy New Year, and thank you for tuning in tonight. Tonight, we are so excited to be amongst 3 distinguished genetic experts and research scientists who will discuss important topics such as the impact of genetic ancestry, genetic testing, health equity, and more. But before we hear from them, I will do a brief highlight of the DREF Research Matters for All of Us initiative. In 1967, Delta Sigma Theta Sorority Incorporated established the Delta Research and Educational Foundation, also known as DREF, as the major nonprofit organization to support charitable and educational programming beneficial to African American women and their families. DREF, along with our collaborative partners, Delta Sigma Theta Sorority Incorporated and the National Council of Negro Women, are conducting a national health initiative entitled Research Matters, Creating Possibilities to Achieve Health and Wellness for All of Us. Since 2017, DREF has received funding from the National Institutes of Health, also known as the NIH, All of Us Research Program. We are proud to inform you that we have been funded for yet a fourth year. Collectively, we are committed to educating and encouraging all individuals and underrepresented populations to be a part of the solution to achieve better health and wellness for their families. In 2015, President Barack Obama introduced the Precision Medicine Initiative. A part of Barack Obama's Precision Medicine Initiative, the All of Us Research Program plans to improve health outcomes for the African American community and personalized medicine. So what is personalized medicine or precision medicine? Precision medicine is personalized care for each individual that considers your genes, environment, lifestyle, age, or even where you live. Because current medicine is a one-size-fits-all approach, precision medicine is taking an innovative approach to personalized healthcare by providing the right patient, the right dose of the right medication at the right time. Indeed, we all are different, but when we visit the doctor, our diagnosis, prescriptions, and treatments are often the same. And since we have genetic differences, doesn't it make sense to have healthcare tailored specifically to the individual? Well, tonight, our panel will address factors that contribute to those genetic differences and risk and how they impact our health, lead to breakthroughs in biomedical research, and more. Throughout the event, please scan the QR code or type in the bit.ly link at the top of the screen. We're at the bottom of the screen to complete our engagement exit survey. Your responses are very helpful for planning future events. The code also provides access to our social media platforms, as well as the vanity link to learn more about the All of Us Research Program and the DREF Research Matters for All of Us initiative. Now to the moment that you all have been waiting for, we will move on to our discussion for the evening. I am so honored to introduce to you our moderator and panelist for tonight, Dr. Altavis Ewing. Dr. Altavis Ewing is a clinician scientist with over 10 years of genetic counseling and health disparities research experience. She earned a PhD in genetics and human genetics with a specialization in genetic counseling from Howard University in 2011. During her training, she spent time at the National Institutes of Health and the Human Genome Research Institute and the National Cancer Institute. She completed a Cancer Health Disparities postdoctoral research fellowship at the Johns Hopkins University Bloomberg School of Public Health. Dr. Ewing has dedicated her career to ensuring the emerging genetic and genomic resources, services, and technologies do not further exacerbate health disparities and inequities. Her unwavering passion for health equity and inclusion has facilitated opportunities for her to engage with various audiences in the genetics and genomics industry. She also has experience serving as a trusted and committed healthcare liaison to marginalized, medically underserved, and underrepresented communities participating in research. Her scholarship focuses on inclusion of diverse patient populations in cancer genetics research and the development of ethically sound educational strategies to better serve and address the needs of the medically underserved populations. Currently, Dr. Ewing serves as a senior science lead and strategist on the Global Health Equity and Population Science, also known as HEPS, team at Genentech. Please welcome Dr. Altavis Ewing.
Thank you so much, Dr. Dixon, for that kind welcome and introduction. It is truly my honor and a privilege to be with you tonight. I really have the opportunity to engage in what will be a conversation with two individuals who I really look up to as mentors, two individuals who are really leaders and pioneers in the space of genetics and cancer health disparities. So tonight we will engage in a conversation with Doctors Rick Kittles and Sean Kimbrough. And I'm actually going to let Doctors Kittles and Kimbrough introduce themselves for tonight. So Dr. Kimbrough, would you like to start with the introduction?
Yeah, thank you very much. I really appreciate the opportunity. This should be fun. I'm not up yet. Yeah, okay. Hey, thank you very much. Appreciate the opportunity. I'm currently working at North Carolina Central University, where I am a professor in biology and also participate in the biomedical biotech, the Julius L. Chambers Biomedical Biotechnology Research Institute, and have spent a lot of my career bouncing around doing health disparities related work from triple negative breast cancer all the way now even to type 2 diabetes in rural populations. And so I'm really happy to be here. My background is mostly molecular biology and now community engagement and connecting the two.
Thank you, Dr. Kimbrough. And Dr. Kittles, if you will introduce yourself, please.
Yes, I am Rick Kittles. I am the Associate Director for Health Equities at the City of Hope Comprehensive Cancer Center here right outside of LA in California. I am also a Division Chief of Health Equities within the Department of Population Sciences. And my research focus is obviously on health disparities, in particular cancer disparities, but the bulk of diseases that disproportionately impact people of African descent. That's been my focus since I started my career. And I also am a co-founder and scientific director of a company called African Ancestry, where we do DNA testing and tracing lineages of African Americans back to Africa.
Thank you. So tonight we have the Herculean task of really talking about the importance of genetics research and why individuals who look like ourselves and individuals from other underrepresented populations should consider participating in research. I am a fan of history, as I know the two of you are as well. So I'd like us to go back in time to 2003. The human genome has just been sequenced. If we can start by telling the audience a little bit about where we were at that time, and then if we can end by telling the audience in terms of what inspired us to reach this standpoint where we are today, where we are engaged in the genetic space and in the cancer health disparity space.
Oh, okay, that's a great question. I guess I could start. 2003, I was a young assistant professor at Howard University in the Department of Microbiology, working at the National Human Genome Center at Howard, part of a team of African-American scientists who were actively involved in trying to understand diseases that disproportionately impact people of African descent. But the question as it relates to the Human Genome Project is interesting because, you know, we think about the project, the finishing of the genome around 2003, but we have to remember that, you know, a good 10 years went into that. And so at the start of the sequencing of the human genome, I was in graduate school. And I was in graduate school at George Washington University. And I remember reading about all of this, this work and the attention. And I started my dissertation research at NIH. So I was in a lab at the National Institutes of Health. And I remember the amount of seminars and meetings that we would have and where scientists from all over the world would present on the sequencing, the process, where we were and these updates. And it was just so insightful in terms of, it was almost like discovery. It was like going and discovering new lands. And, but in this case, it was discovering what it was that makes us who we are, the DNA that we get from our mother and our father that makes us, look the way we look and susceptible to certain diseases that we have. And so that was a very exciting time. And I remember I was in graduate school. For me, it was like I was riding that wave of information collection and of leveraging that information to answer more questions about health. We all felt that the human genome was going to improve human disease, our understanding of human disease and overall human health. But some of us believed it more than others. Some of us felt that, once we unlock this genome, we decode the DNA, it'll be the key to medicine. But there were many of us who were a bit less optimistic, and knowing that this is just going to be a sort of a guide or a rule book in a sense of a lot more work to come. And it wasn't until I was at Howard where I realized that there was a context for everything. Here we are talking about science and technology, but the context for us as African Americans was political. And so it didn't matter what NIH or what Wellcome Trust or what all these other entities were doing. As it related to Black people in our communities, all of that stuff didn't disseminate down in terms of benefits. And so it was very interesting for me. It was a learning experience in terms of really getting a grasp on the reality of communities of color.
Thank you, Dr. Kittles, for that rich history. And Dr. Kimbrough, can you tell us a little bit in terms of where you were in 2003?
So I'll tack on a little bit and to what Rick has said. So in 2003, I was at Clark Atlanta University. I was a young assistant professor there with the program called Research Centers for Minority Institutions. Actually, that's where first time I saw Rick Kittles stand up to the mic, and I had asked one of my colleagues. I said, "Oh, look, there's a brother doing some genetic research." And prior to that, just like Rick said, you start to hear there was courses offered at Cold Spring Harbor on how to do the type of high throughput sequencing, how to isolate DNA fragments. I remember in grad school, my first introduction into genetics research was actually using, they used to put the DNA from a human and take a chromosome and put it into a hamster cell line. And they would do these hybridization studies on southerns, which are places of putting DNA onto membranes, and then you would identify bands. And I remember identifying the location of a gene that now there's two of them or two versions of them. So that was my first introduction to genetics. And I think taking that further, when I took on the appointment at Clark Atlanta, realizing that it's an opportunity to share that information with students at a HBCU. And we were having some interesting conversations at the time about the impact of genetics. And in particular, I do triple negative breast cancer research. And so that was a real push for me. And it wasn't until the realization that there was some behavioral differences in these cell types and these tissues that made me really grasp this idea that, we're moving to this new era where we can now, instead of doing the old school sequencing, we were talking about that beforehand, how old school and how was the art and how things changed with that technology, and actually afforded us the ability to really get more creative and allow us to look forward in how we were addressing health disparities besides and beyond the behavioral pieces.
Mm-hmm.
So thank you both for those perspectives. And I like to actually add my own. And ironically, there are similarities in both of your stories. So in 2003, I was actually an undergraduate student at Rhodes College in Memphis, Tennessee. And I was a biology major. And then that next year, my senior year, I had the pleasure of taking a genetics course. So it's fall semester, senior year. I engaged in a number of research opportunities in a lab where it was just me, my Petri dishes, and my pipettes. And I realized that I was not the happiest person. And that was really because I missed that social interaction. So a genetic counselor actually came to my genetics course that fall semester of my senior year and shared information about her profession. And I learned that genetic counselors had the privilege of interacting with patients on a daily basis, talking to patients about their personal health history, their family health history, and really connecting the dots for those patients to help them understand if genetics and genetic testing could be a tool that is useful in guiding their medical management. So for me, a light bulb went off and I knew that I wanted to pursue the field of genetic counseling. But more importantly, Dr. Kimbrough, to connect it to your story, I was also inspired by the field of genetics because I saw it as being that key to medicine, as you alluded to, Dr. Kittles. Because at the time, there were a lot of statistics coming out that African-American women were less likely to be diagnosed with cancer, but more likely to be diagnosed with triple-negative breast cancer, the most aggressive form of breast cancer, and more likely to die from breast cancer. So I really saw genetics as being a solution to address those inequities. And I also saw my presence in the space of genetics as being a solution to help translate and disseminate that information to people who look like me and people from other underrepresented populations. So for me, there was no question that I was going to Howard University, where Dr. Rick Kittles and his colleagues had really engaged in some dynamic research and were really making history during his time. So I had the privilege of going to Howard, studying genetic counseling, and it was during my cancer genetic counseling rotation where I realized it's go time. Like, this is where I will see genetics in action. This is where I will see genetics help address those issues, those problems that really piqued my interest years ago. And during that rotation, I saw numerous white women walk through the door. However, I did not see many women who looked like me walk through that door. So in my mind, I wondered about the barriers to genetic counseling. And when I did see a woman who looked like me walk through the door, she did not always qualify for genetic testing for various reasons. Sometimes it may have been because she was not young enough to qualify for testing based on her personal history of breast cancer. Other times it could have been because she did not have enough information about her family health history to really qualify her for genetic testing. So in my mind, there was a disconnect. Of course, I walked through the door thinking genetics would help solve a problem, but people who look like me were not qualifying for the testing. And when we qualified for the testing, and we received our test results, I later learned that we were more likely to receive those results that were not informative in terms of guiding our health management. We were more likely to get a result that's called a variant of unknown significance. So that really left me distraught. And I marched right to the director of my genetics program, and I told Dr. Verl Headings that I want to help address the solutions. I want to ask the questions that people are not asking. I want to come up with the solutions that people have not come up with, because I cannot continue to see my community suffer. And I transitioned into a doctoral program where I could conduct research. And ultimately that led me down the path of identifying factors that influence people of African descent to participate in cancer genetics research. So really understanding those barriers and those facilitators to participating in research. And that's why I'm immensely passionate about us being present in the research space, not only as participants, but in various capacities. And I'd actually like us to talk about that tonight. We know that our community is not always trustful of the medical system for valid reasons, because we know that we've been mistreated and abused in the past. Drs. Kittles and Kimbrough, I'd like us to tell our community some information in terms of ways that we can overcome that mistrust, and even some of the strategies that are in place today to really overcome that mistrust and to really build trust between researchers, between institutions, between healthcare systems, and the various communities that are underrepresented.
Okay. So from my perspective, I would say to the community, what I do when I go out to Halifax County in rural North Carolina, we have a lot of discussions about why participate. And the one thing that comes up a lot is, as a response is, we're glad you're out here doing this work.
Mm-hmm.
Almost unanimously, we've had conversations with folks in the community where, boy, we're so glad that HBCU is out here, and we are glad to see you out here. We trust you. We know if you guys say it's okay, we're fine with it. We've also even presented data to some of the state health agencies, and where they have been pleasantly surprised, I think, to some extent, because they didn't expect that HBCU could go out there, capture that data, capture that information. This is related to COVID, for example, and actually communicate with a population that they might not have been as successful in getting into. So I think that's one aspect. I would say that, there are the presence, people who look like look like me, look like part of the family, is very essential. We brought students out into the community to do that. Even to this date, we get phone calls because there's a connection there. There's a innate trust and a cultural expertise that HBCU brings to the table that a lot of maybe Research One institutions don't innately bring with the community, and not to the level that an HBCU does. So I would say that, this participation, and then we going back to the community to share with them some of the results has been so powerful, and they've been happy to be part of it, and now they get to see their impact on the actual results, and maybe look forward a little bit. I like to think forward a little bit with them and my folks, and share with the fact that, hey, this is what you guys did for us. And we're finding things now in the case of type 2 diabetes, for example, that were not known before. And I collaborate with Dr. Kittles. I think it's always important for scientists like us also to communicate and work together, which I think we are moving toward doing more of that as we move forward, because it's personal. I had a scientist once tell me health disparities research didn't impact him. He really did it because of the money, or it was just science. Mm-hmm. And he told me, he said, you know what, you need to hire somebody who this impacts, who this really has some meaning. And I heard him, and I thought it was very important. And he was not from the United States.
So I agree. I agree with what Sean is saying. I think we have to be honest, right? There is no turnkey solution to this mess. This mess has been created because of, once again, the context of the history of Black experience. And so don't think that, let's do a show on PBS, or let's do, a donation to this HBCU that is going to change something. Most Black folk, and Sean is a good example. I mean, most of the time when we go out into the community, we don't have no problems. When I go to the community to recruit, they see their brother, their uncle, their father, their cousin, or whatever. You see what I'm saying? And that's because, as a Black PI, a principal investigator, all of my people are represented by that. The community is represented within my people on my team. And so they see that and they respect that. And they know I'm not coming in with no bull crap, meaning, I'm not gonna come in there, let's do the genetics of ingrown toenails. I know this is so important for your community. No, I know I'm sensitive. I know what those issues are in the Black community. And so we have to be more assertive. So, okay, let's look at it like this. I've been involved in several successful projects where recruitment was not an issue. And I'll tell you what that looked like. It looked like Black folks from the top to the bottom. It looked like engaging communities that we were a part of. So that trust was there, the sensitivities were there. And so it's funny because the community is savvy. If you are a majority investigator, PI, and you hire a couple of old black women as your study coordinators, and they go out into the community, most of the time they can peep that. They can see something ain't right. And they'll, the discomfort is there. And it's funny because, you'll say, oh, here's the black face for my project. But then they see everything, the paperwork and the questions and how things are, you could tell. So anyway, the projects I was involved in, we had African-American representation throughout the team. And, in particular, one for hereditary prostate cancer, a national study. We had Black urologists, radiation oncologists, and nurses all around the country that were involved in this. And so when we went out and recruited these families, they knew that this was, for Black folk, and we were going to try to make a dent in understanding prostate cancer. So that's very important. I think it's very important. But just remember, there is no switch that you can turn on and off to fix this.
Thank you, Drs. Kittles and Kimbrough. You all said a number of things that resonate with me as well as a clinician. As one of the few Black genetic counselors across the nation, I did not have an issue really getting individuals of African descent to provide informed consent to undergo genetic testing. But I do know that that is something that my colleagues who do not look like me or who may come from different backgrounds do struggle with. And I think it was a similar concept. Individuals, my patients, knew that they could trust me. They knew that they were looking at their daughter, they were looking at their niece, their cousin, a sister, and they knew that they were sitting in front of someone who had their best interest at heart, which has been my intent day one. And I think you both articulated that we are all here with a purpose. We are all here with the intent of making sure that our community does not get left behind and that our community benefits from the research advancements that are ensuing. And Dr. Kimbrough, as well as Dr. Kittles, you both touched on what we know of as community-based participatory research. And I would like for us to talk a little bit more about that, because for me, I was exposed to CBPR. That's the acronym that we will use moving forward. I was exposed to CBPR when I was a graduate student at Howard University. And that meant that we were conducting the research with the community. We, as researchers, did not come up with those questions and then go to the community to ask them to participate. Instead, day one, we sat at the table with the community and we asked, what are the topics that are most important to you? What would you like to see us work together to address? And it was a true partnership. And for me, being in 2021 and seeing a lot of the innovation that's ensuing, I cannot help but smile because I see a lot of this innovation having that CBPR foundation. And I know that this is a methodology that both of you are highly skilled in. So Dr. Kimbrough, maybe if you can start by telling us a little bit more about the CBPR experience that you've had at NCANT and the success that you've had there.
So I'm at Central, not
about
A&T. Oh my goodness. So keep in mind, I'm a bench scientist. So I was trained as a bench scientist. And when I took over the reins at North Carolina Central University at the Julius L. Chambers Biomedical Biotechnology Research Institute as director, I learned that one of the projects actually had an outreach component to it. And so we had a fantastic investigator that kind of showed me some of the ropes. And then she left, and I was left with a whole program. And I had to figure out, okay, what's going on with this? And I've had a fantastic community person, Miss Ruby, who educates me. And I actually start to learn more about that process of sitting down with the community. I used to go out and hang out with the community, and they would talk to me, and they would crack jokes. I sit in the back kitchen in the church, and the ladies would sit there and be talking about me, feeling like I was a little too skinny and need to get some more food. And we would have a great relationship. And you start listening to folks. And then when you formally ask, what are on their minds, and what's bothering them, they say type 2 diabetes, they take obesity, they say, talk about cancer. And then you start to get that input, whether you do it formally or informally. We also learned a couple things. We also employed some of the folks in the community to actually participate and actually help recruit. So we actually gave temporary jobs with the community, educated those individuals in the community how to deliver health information. And we're still out there 10 years later. We still run back and forth. They call me up, say, hey, we need some help with COVID. We need some help with this. And we're actually in a location that's really rings home with folks. It's called Tillery, North Carolina. And it's one of the sites of 40 acres and a mule. And so it's one of those establishments where they set up there trying to try that experiment, see can we get 40 acres and a mule to folks. And it's still there. And we actually meet in that community. And one thing I would add to some of that, we did learn that most of our almost 99%, 98% of the folks on our teams are African-American. We also found, even if we brought someone in that was European-American onto the team, if they wore an NCCU t-shirt, they were in like Flynn, no problem. They were on board. And we actually got to the point where people would let us know where other universities were out in our area, as they say, in our county. And so I just take a lot of pride in that. So it is that back and forth communication that's essential. That binding trust there that you have because of your ethnicity, and some of those communities out there, they're very diverse. There's a American Indian population, there's African American, and we get a lot of interesting dynamics there. But it's really been a very powerful experience for me, and it's been a learning process. But it's really allows you to get at that piece of the impact of behavior and environment on the genetic piece, because it's not just the genetics, it's a lot of times it's combining all those three things together.
Yeah, that's a good point. That's a good point. Now, I'm not gonna repeat, much of what he said, because what he said was absolutely right. We have to remember that CBPR is not something that happens quickly. Once again, it's a process. And that process of engagement with the community is a back and forth. And it's a humbling experience, actually. And that's why for the most, a lot of investigators can't really manage that, because they were never trained in humbling themselves as it relates to the community. It's more so, this is what I know, and I'm going to tell you, why you should be eating those fortune cookies or whatever. You know what I'm saying? It's like, it's a two-way process, and it takes time. And part of it, when you really have it clicking, is when you've built that trust to the point where you can go out there and talk about whatever they want you to talk about, and then they will be like, I want to participate in a trial around that, or let's develop a study around this. That's when things really start clicking. And that's different than the model in which biomedical research has operated in forever and still operating. That model is, NIH says, we want to focus on type 2 diabetes in Native Americans. Everybody wants money for their lab. So they come up with these ideas. I'm going to study this gene in this population and write 95% of the grant before they even go to the community and engage the community on the grant. So they'll have their research questions, their methodology, everything already written. And then they'll engage, as they'll walk into the community as a Johnny come lately and say, hey, you want to partner with me on this grant? This is going to help you, as opposed to engaging them in the very beginning. That's the model in which we've been operating on. And that's why, I have really, strong concerns about how quickly we're going to be able to deal with these disparities in communities of color, because there has to be sort of a revolutionary way of thinking as it relates to how do we engage, how do we develop these projects that are going to be beneficial to these communities. We can't continue to use the old methodology.
Thank you, Drs. Kimbrough and Kittles. Dr. Kimbrough, you mentioned that binding trust that we build through CBPR, and Dr. Kittles, you mentioned it being a humbling experience. I think it's also a mechanism through which we can hold institutions and researchers accountable as well. And what really motivates me or inspires me about CBPR is that it's also a way to affirm the concerns and the unique lived experience of our community as well. Because again, we're working with them to come up with the research questions. So we are researching some of the diseases that impact them disproportionately. And we are researching some of the questions that some clinicians or other researchers may have been dismissive of. And I think that is a great way that we solidify that trust with the community as well. But to go back to this accountability word, and this will be our last question before we wrap up with our closing statements. We are at a point where science looks very different in terms of the way that we are engaging underrepresented populations. How can we ensure that the researchers, the healthcare systems, the institutions that are engaged in health equity and health disparities research are here for the right reasons? What can we do as a community? What can we do as Black clinicians and researchers to hold those institutions accountable so that we see a solution being posed to addressing the disparities and inequities that persist?
Okay, so I guess Rick is shaking his head at me, so I guess I'll start off. So I think from my perspective, this is really about appreciating the tools that you have at hand and the capacity or the talent that you have at hand. And I think when we think about some of these studies, I think Rick really was talking about this idea of basically where you put the money. I think too many times HBCUs, for example, as an entity is not considered researchers, but they're considered a pathway into the community. And I think as we move forward, we need to not only think of HBCUs as training Black scientists, but they also can do the research. And I think that's being missed a little bit here. And I think there's opportunities here that as we move forward, distribute the resources to some of the HBCUs and historically minority serving institutions would be helpful for some of that, that push forward and sharing and increasing that research effort. You want to feed into that, Rick?
I didn't understand the question. That's why I was shaking my head. What was the question?
So go ahead.
So Dr. Kittles, you and I have engaged in conversations because you are one of my mentors, and we've talked about how important it is for us to hold, whether it's pharma accountable, whether it's researchers who may not always look like the communities that they want to conduct the research on. What information can we share with our community in terms of holding those institutions, holding those stakeholders accountable to ensure that they are not just fly-by-night researchers, or to ensure that they are not engaging in performative allyship or performative sponsorship? So what can we do to hold those institutions and stakeholders accountable?
Right. I mean, it's what can we do to hold them accountable? I think part of the at the initial phase of engagement, right, with these drug companies and researchers and Ivy League institutions, when they come to the community or when they come to the brokers, which in Sean's experience is an HBCU, and that was also my experience too when I was at Howard. When we were at Howard, we built a stellar research National Human Genome Center. I mean, top stellar with equipment, personnel, staff, all of that. And while we made enormous advances in areas of prostate cancer and type 2 diabetes, we provided enormous amount of information in the literature around those areas, ancestry, all of that stuff emerged. Being able to understand population admixture and leveraging that in your study design, all of that stuff we were working on because we were working on Black people, right? So we had to understand that. We had to develop those tools. But for the most part, we were seen as folks who would go out and get samples for the likes of NIH and other institutions, the Broad and Harvard and all of that. And I would always say to other faculty there that that model, we can't continue this model. We cannot continue with this model. We are contributing too much. We have a legacy that we want to leave behind for the next generation. And if we continue to build on that model, then they're not going to have anything. We're just going to go out there and provide access to our community to these other institutions. And so we had to sort of rethink how we would engage NIH, because they would always, and all you have to do is publish a couple of times, and then people all over would say, hey, I see you can recruit African Americans who are deaf. We're doing a study on the genetics of deafness in Blacks. Can you help us? I would get emails like that all the time for all these different areas. And after a while, it was almost like, look, I have students, I have junior faculty. I need them to, if you need help, I need help too in terms of developing these kids, in terms of providing resources for these, to get access to these samples. Not only for me to send you samples, but for us to store samples here and for us to do what we want to do with those samples. So it's not just, I'm a hired gun. It's more so we're going to get something out of this. And that's how the community should think about this, as folks run around with their suitcases full of blood collection vials and stuff. Look, if somebody's coming to your house trying to sell you something, you're going to try to get the most out of that, right? Look at it the same way and protect not just yourself. You got to think about it. It's not just yourself you're protecting. You're protecting your family and then also the community. See, we think, oh, it's just, I just donated my blood to this project or whatever, but you got your blood from your family. You share DNA with everybody in that house. You got half of it from your mother, half from your father. And so there is a community there that's linked to that DNA. And we should be careful and wary of who we give this to, because, everybody is not, I think we know about that. Even the young folk who just went through 4 years of a mess, y'all should at least understand.
Thank you, Drs. Kimbrough and Kittles, for really emphasizing the credibility and commitment aspects and why those are important. And I think my contribution to that question would be, as a community, it's very important for us to be empowered as participants in research. And that means that we need to know our rights as participants. Familiarize yourself with the informed consent process and understand that if you are engaged in research and if at any moment you feel uncomfortable and you don't want to proceed, it is your right to withdraw your consent from that study. It is your right to ask questions, unapologetically ask questions, because the research community owes those answers to you. So never feel as though as a participant that you are disempowered, because you are not. You hold more power than you may realize. And I think if we as a community realize that, then I think we will shift our mindset about research, and we will realize that research is critically important in terms of ensuring that the tests that are developed, the diagnostics, the screens, the therapies that are developed, that they work for us, and that we are going to be less likely to experience adverse effects from some of those therapies and those drugs. So be informed, be empowered. And I think Dr. Dixon wants to come back and ask a few questions before we wrap up. So thank you very much, Drs. Kimbrough and Kittles, for the lively discussion and contributions.
Thank you.
I think she's on mute.
I think you're on mute.
Great. Thank you to our distinguished panelists for a very insightful and important discussion. Before we take any questions from our audience, again, if you haven't completed the engagement exit survey, please hover over the QR code at the bottom of the screen or type in the bit.ly link in your browser and complete the engagement exit survey. Again, your responses are very helpful for planning future events such as this one. And again, our code also provides access to our social media platforms, as well as our vanity link to learn more about the All of Us Research Program and DREF Research Matters for All of Us. So now we will take questions for our panelists. They will answer, may have 1 to 2 questions for our panelists. The first question that we have is, what are the initial steps to get the community further involved in research, and how can we expand these type of discussions in our community?
Oh, I'd love to answer that. I think a good way to do that is to develop these community advisory boards where you have, experts from the community, and they don't necessarily have to be lettered experts. These are folks who know the community, know what the issues are, but then also once they want to be engaged in biomedical research, they can help develop opportunities for you to build that trust and educate the community around these issues. A community advisory board would be one of my first steps in that process.
And I would just add that I agree. That is exactly what we've done out in the rural communities. It is the best way, I think, to actually get the message back and forth. And we've also found, sometimes you'd be surprised. Of course, we've gone to churches, but even in that arena, it has been churches that come together as a group and ask, hey, we're willing to participate as a collective. And so I think that's another way to achieve it. And just yesterday, we were realizing that the students had some questions. And so we've actually engaged some students to assist and kind of guide some of our efforts.
Dr. Ewan, did you want to expand on that?
One thing that really comes to mind for me, as Dr. Kimbrough mentioned, is really engaging churches. I've had a lot of success in terms of going to provide presentations to various churches, to various community organizations, to various sororities and fraternities, just identifying various organizations within the community that really has the heart and the ear of its community. To really help disseminate that information. I think that's going to be key in terms of engaging the communities in research and, again, empowering them to stay engaged.
Absolutely. I totally agree. As a cancer research scientist myself, I do believe in going out into the community and having those discussions with those cancers or diseases that affect someone that looks like me makes a greater impact with our community actually listening to us and asking those more thoughtful questions when they go to the doctor. They're more educated of what they need to know when they do see that medical profession. So that is really, really good good discussion from you all. We will take one last question. So besides the historical transgressions that we all are aware of, do you think there are other barriers to why African Americans don't participate in biomedical research?
Well, I think, there. See, but the historical context underlies all of that. But there are many barriers, right? There's the fact that they're not asked to participate as often as white folk. They may be underinsured, and so insurance is a financial impact on participating. And then there's, of course, education around these issues. So there's a lot of barriers that are impacting the participation in these studies.
I'll add to that and include, if you're looking at the rural area, you're talking about transportation.
Mm-hmm.
And one thing that we've done is that we do our sample collection in the community with community folks. If we're going to do sample collection, we don't have them try to get to a clinic. That's a little different if you're doing cancer work where they have to go to the clinic. But in the case of type 2 diabetes, it's not the case. And I think it's that connection. Also, we do something called social recruiting, which you center your recruiting around an event. And so as I would tell some of the folks, you know, if someone comes up to you and they say, hey, would you like to participate? Do understand your rights, make that assessment, and understand that opportunity, that might be an opportunity really to participate. We've done that at fairs. We've done big, large events and showed up and just put up a tent and really just showed up, and it's been amazing. So I would say that, you know, transportation, socioeconomic, we found that also in the case of the COVID piece, some populations did not want to be identified. They felt like, you're going to take my information, I'm not going to get tested. And so we found that to be a barrier, but we found transportation to be a major problem in some of this. And the same thing at Grady Hospital when I worked at Emory University. People didn't have transportation, didn't have childcare to come in to do that survey while their child, you know, so that was another problem as well.
Yeah, I definitely have to piggyback on that. That's an issue we see even here. As we go up north in the more rural areas, rural communities, or just communities where the geographic distance is broad, and folks don't have transportation to come in for treatment or the likes. And so that's something that I think, you know, we really need to think about as we start modeling increasing the diversity in these studies. What is it going to take?
And I'd actually like to take a different angle in addressing this question. For me, I think one of the biggest barriers for our engagement in research is that we do not hear or see enough of those success stories. So when we participate, what are some of the benefits that we are experiencing afterwards? Let us hear about those genetic studies where it was not until they studied a Black family that they identified a genetic target for conditions such as familial hypercholesterolemia, which is a major form of heart disease. What are some of those other success stories? I would like to see people share their testimonies in terms of their positive experiences when they participate in research. I think that will make a big difference in terms of helping us to recognize the value of research and really recognize our value of being present and participating in research as well. I think it's also key for us to highlight and showcase more of those accomplishments of Black scientists, of other scientists from underrepresented populations as well. I think that will help really garner the trust of our community and help our community understand that we are here again with a purpose, but it really takes all of us as investigators, as participants, as funders, as policymakers to really overcome some of those barriers.
All right. Thank you so much to our panelists, and to piggyback off of Dr. Ewing. Yes, indeed, it does take all of us. One word that comes to my mind is community. So we have to address our community as major stakeholders. The All of Us Research Program is inviting 1 million people across the United States to help build one of the most diverse health databases in history. We welcome participants from all backgrounds. The All of Us Research Program provides genetic testing, which will provide more information about you, your family, and your family history. Researchers will use the data to learn about our biology, lifestyle, and environment, and how they affect our health. This could help them better understand treatments and develop treatments, and to prevent different diseases. So as we close for the evening, we again would like to thank our panelists for dropping those gems of knowledge to those Black scientists. It's very empowering to see experts in our field that look like us. We invite you to follow us on our social media pages and visit our website at www.joinallofus.org/DREF to learn more about the All of Us Research Program and the DREF Research Matters for All of Us initiative. Again, if you haven't done so already, please complete our engagement exit survey so that we can plan more events such as this one. Again, thank you for joining us tonight. Have a good night.